Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health. Cherish every movement. A growing body of empirical evidence suggests that for persons aged 60 and older, specifically focused exercise modalities may provide significantly higher and more functionally relevant health benefits than traditional steady-state aerobic exercises like walking. Recent studies highlight that specific exercises designed to challenge strength balance, proprioception, and mechanosensitive tissues can more efficiently counteract age-related reductions in muscular power and strength, postural stability, bone mineral density, and certain cognitive functions, frequently necessitating less overall weekly exercise duration than conventional aerobic programs. This analysis consolidates evidence for 5 prioritized exercises in modern geriatric exercise protocols, critically evaluates potential physiological mechanisms underlying their effectiveness, and offers operational guidance for proper execution and progressive adaptation to ensure safety and optimize benefits. Summary and principal evidence. A significant contribution to this literature is a longitudinal study published in 2024 and affiliated with the University of Copenhagen. The 5-year trial involved 8,000 community-dwelling persons over the age of 60 and compared outcomes between participants who substituted their usual walking prescriptions with a designated set of 5 targeted exercises and those who maintained walking-based regimens matched for frequency. The Copenhagen researchers saw much better results in the targeted exercise group, a 73% decrease in fall occurrences, and an 89% enhancement in overall assessed muscular strength compared to the walking group. The observed effect sizes led to replication efforts, prompting the original researchers to do 2 separate replications to confirm the results. The targeted exercise group attained similar results while utilizing almost 40% less exercise time than the walking group. Quantified health enhancements included various physiological indicators that hold clinical significance for aging demographics, a 31% superior enhancement in systolic and diastolic blood pressure, a 67% reduction in self-reported joint discomfort, in contrast to a 12% reduction among walkers' advancements in reaction time and mobility parameters, and a noted increase rather than simple maintenance of bone mineral density at clinically pertinent locations. A specific exercise in the Copenhagen regimen has garnered notable interest due to independent research from Harvard Medical School that correlate the movement pattern with indicators of cellular and organismal lifespan. The Harvard analyses indicated that the performance of the contralateral stability movement was associated with a 42% enhancement in composite longevity markers, an effect the authors partially ascribed to the activation of mechanotransduction pathways and corresponding molecular signatures indicative of more youthful cellular behavior. Moreover, the activity was widely accessible. 94% of older adult participants in those studies were able to execute it immediately without specific equipment or prior training. While observational connections do not establish causality, the convergence of population clinical and mechanistic data offers a compelling justification for prioritizing certain activities that concurrently engage musculoskeletal neuromotor and sensorineural systems. The subsequent sections analyze in decreasing order of significance, as dictated by the Copenhagen Protocol, the 5 exercises providing empirical evidence, where applicable elucidating immediate physiological mechanisms and outlining practical guidance and progression strategies appropriate for older adults. In the absence of direct randomized evidence, conclusions are cautiously derived from mechanistic literature and trials of similar modalities. 5th, in the Copenhagen sequence wall, push-up with isometric retention, exposition and substantiation. The wall push-up with an integrated isometric hold enhances fundamental upper body and core strength while ensuring safety and adaptability for older persons with differing baseline abilities. Empirical assessments validate its effectiveness in functional fitness programs for older populations. A 2023 randomized controlled trial published in the Journal of Aging and Physical Activity evaluated adults over 60 and found that an 8-week regimen of wall push-ups with isometric holds resulted in a 34% greater enhancement in objective upper body strength compared to traditional upper body exercises. A supplementary study from the University of British Columbia recorded diverse advantages subjects who engaged in the workout thrice weekly for 12 weeks, shown a 41% enhancement in pushing strength and a 23% rise in reaction speed. Investigators ascribed the cognitive benefit to the isometric component, positing that prolonged muscle contraction enhances proprioceptive acuity. Mechanisms. The physiological basis for the efficacy of the wall push-up is grounded in several known principles. The activity primarily focuses on functional pushing patterns prevalent in daily activities engaging the pectoralis major anterior deltoid and triceps brachii, while also activating scapular stabilizers and the anterior core as secondary muscles. Secondly, intentionally prolonged eccentric and concentric phases coupled with an isometric hold enhance total time under tension, TUT. In older individuals, gradual improvements in strength are typically more successfully attained by extended muscle contractions and regulated tempo rather than through high-velocity or impact-intensive repetitions. The prolonged contraction elevates metabolic load and mechanical tension, key stimuli for muscle protein synthesis and neuronal recruitment, while the isometric hold engages a greater number of motor units, enhancing neural activation patterns and intermuscular coordination. Augmented proprioceptive input during prolonged holding may enhance sensorimotor integration, facilitating faster reaction times and more accurate motor planning. Guidance and advancement. The practical application commences with the individual positioned facing a stable wall at approximately arm's length. Position the palms flat at shoulder height, marginally wider than shoulder width, with fingers oriented upward or slightly inward based on wrist comfort. Assume a firm foot stance with feet either together or slightly apart, ensuring a straight alignment from head to heels by engaging the anterior core to avert hip sagging. Gradually bend the elbows until the nose nears the wall, performing a controlled eccentric phase. At maximal lean, sustain the position for 3 to 5 seconds, ensuring spinal alignment and aggressively engaging the chest, shoulder, and arm muscles. Revert to the initial position by gently extending the elbow to full extension without hyperextending. Breathing inhale at the lean, sustain, shallow breathing, or a brief, comfortable breath. Hold during the isometric phase if feasible, and exhale during the concentric return. Commence with one set of 5 repetitions, advancing to 1 to 3 sets of 15 repetitions as strength and endurance enhance. Options for advancement. Augment mechanical load by positioning feet further from the wall, hence increasing body weight borne by the arms. Decrease resistance by positioning oneself nearer to the wall or executing incline push-ups on a countertop. Extend hold duration, e.g., from 3 to 5 seconds to 8 to 10 seconds, to accentuate isometric endurance. Incorporate a reactive element, brief regulated pulses at the conclusion of each repetition to enhance power and proprioception. Alterations and security. For wrist discomfort, execute the activity on fists or using push-up bars. For shoulder pathology, restrict movement to a pain-free range and maintain scapular stability. Oversee initial sessions for those with cardiac risk hypertension or uncontrolled pulmonary disease. Assess perceived exertion and blood pressure response as clinically warranted. Fourth, seated leg elevation with resistance. Exposition and substantiation. The seated leg lift, enhanced with incremental resistance, focuses on the lower limb muscles vital for ambulation, stair climbing, and transitioning from a seated posture. A 2024 controlled trial, published in the Archives of Physical Medicine and Rehabilitation, investigated seated leg lifts with additional resistance in adults over 60, revealing a 28% increase in typical walking speed and a 45% improvement in stair climbing capability among participants engaging in progressive, resisted seated leg lifts. These improvements manifested functionally enhanced gait velocity, and stair performance correlate with diminished impairment and lower probability of institutionalization. Mechanisms. The seated leg lift targets and fortifies the quadriceps femoris and hip flexor complex muscle groups that function synergistically throughout the leg swing and support stages of walking. The quadriceps produce the extension torque required for standing and climbing stairs. The hip flexors aid with limb progression. Unilateral training is beneficial since it mitigates contralateral compensation and aids in rectifying side-to-side asymmetries that elevate fall risk. Progressive overload is essential. Older persons can achieve hypertrophy and brain adaptation when stimuli are appropriate and recuperation is sufficient. Guidance and advancement. Assume a seated position on a firm-backed chair with an upright posture, feet flat on the ground, and knees at approximately 90 degrees. Without trunk inclination or momentum, extend one leg until it is parallel to the floor or as far as proper form allows focusing on quadriceps contraction and maintaining a neutral pelvis. Hold for approximately 2 seconds, then lower over 2 to 3 seconds, avoiding floor contact to maintain tension. Exhale while extending and inhale while descending. Recommend 10-15 repetitions for each leg, 2 to 3 sessions weekly. Advance by incorporating ankle weights, 1 to 3 lb initially, or progressively augmenting band resistance. Augmenting repeat velocity, or incorporating short isometric holds at the apex 2 to 5 seconds. Executing eccentric stress by descending at a reduced pace, 4 to 6 seconds to accentuate tendon and muscle adaptation. Alterations and security. In cases of knee osteoarthritis or patellofemoral discomfort, restrict extension to a pain-free range and refrain from quick ballistic motions. Implement isometric quadriceps contractions when dynamic movement is restricted. Observe for indications of fatigued, compensatory hip hiking or trunk inclination. Revert if technique declines. Third, standing heel, rise with balance difficulty, exposition and substantiation. The strength of the calf muscles, primarily the gastrocnemius and soleus, is often overlooked in older individuals, yet it is essential for locomotor propulsion, venous return, and postural stability. A 2023 prospective cohort study by the National Institute on Aging identified calf strength as a significant predictor of maintained independence over the following decade. Participants with the strongest calf muscles were considerably less likely to need assisted living and encountered fewer injurious falls. Complementary research from the Longevity Research Center in Japan correlated the ability to execute single-leg heel raises with biomarkers of biological age. Adults capable of performing 20 consecutive single-leg heel raises demonstrated arterial flexibility and other indicators akin to those of significantly younger individuals. A 12-week progressive calf training regimen in a diverse older population yielded moderate enhancements in specific cognitive assessments potentially facilitated by enhanced peripheral circulation and rhythmic afferent input to sensoromotor and cognitive networks. Mechanisms. The calves operate as a muscle pump, enhancing venous return from the lower limbs by compressing deep veins during contraction and driving deoxygenated blood upward. Muscle weakness may lead to venous pooling and peripheral edema, adversely affecting cardiovascular and cognitive health. Rhythmic contraction also improves peripheral perfusion and may slowly enhance cerebral blood flow. The plantar flexor power facilitates swift push-off during walking and delivers the forefoot force essential for reactive balance recovery following disturbances. Incorporating a balancing component activates the vestibular and proprioceptive systems, enhancing integrative control and reducing the chance of falls. Guidance and advancement. Position yourself behind a sturdy chair or countertop with your fingertips making mild touch for support. Feet positioned at hip width apart and parallel. Gradually elevate onto the metatarsal heads, maximizing heel lift, while channeling effort via the big and second toes to preserve ankle alignment. Pause at the apex for approximately 3 seconds. As stability develops, diminish support to just fingertip touch. Gradually lower the heels with control over approximately 3 seconds. Breathing inhale during preparation, exhale during climb, inhale during descent. Commence with 1-2 sets of 10 repetitions and advance to 2 to 3 sets of 20-25 repetitions. Upon achieving 25 repetitions with stability, transition to single-leg heel raises. Strategies for progression. Enhance eccentric emphasis, 5 to 6 seconds descent to improve tendon resilience. Incorporate external resistance by utilizing a weighted vest or a single dumbbell grasped in one hand. Gradually incorporate unstable surfaces cushion foam pad to enhance advanced balancing challenges. Alter the tempo during sessions to enhance both endurance and power, brief explosive increases for 1 to 2 sets. Alterations and security. In cases of substantial peripheral neuropathy or vestibular impairment, ensure two-handed support until balance responses are dependable. Observe for cardiac symptoms in people commencing high-repetition plantar flexion if alterations in preload induce symptoms. Advocate for footwear using a minimal sole to enhance ankle proprioception. Nonetheless, employ supportive shoes if experiencing foot pain or balance issues. Modified squat to a chair, sit to stand, exposition and substantiation. Squatting is a fundamental multi-joint exercise essential for independent function. The chair-supported version provides a safety framework and promotes proper biomechanics. A 2024 meta-analysis of 42 trials with over 15,000 participants revealed that chair-modified squats are safe and alleviate knee discomfort when executed with proper technique and incremental advancement. The sit-to-stand movement is frequently utilized as a measure of functional capacity. The inability to execute it without arm support forecasts heightened mortality and institutionalization risk. A randomized research conducted by the Stanford Longevity Center assigned persons over 60 to perform chair squats 3 times per week for 6 weeks, resulting in a 47% enhancement in lower limb power and significant improvements in gait speed, alongside alterations in motor cortex activation observed using functional MRI. Mechanisms. Squats activate the gluteal complex quadriceps, hamstrings adductors, and posterior core muscles. An effective approach highlights a hip hinge that begins the descent using the gluteal and hamstring muscles, hence minimizing excessive forward knee movement and anterior shear stresses. The chair offers a proprioceptive signal that promotes a posterior weight transfer and regulates depth. Maintaining consistent tension-like contact with the seat without complete relaxation prolongs time under tension and promotes neuromuscular adaptation. Guidance and advancement. Choose a stable chair of suitable height to ensure that the knees form an approximate 90-degree angle while seated. Position your feet at shoulder width or slightly wider with toes facing forward. Cross the arms over the chest or extend them forward for stability. Commence descent by retracting hips posteriorly, maintaining an upright chest and neutral spine. Drop over approximately 3 seconds until the gluteal region gently meets the chair without complete relaxation. Instantly reverse by driving through the heels to an upright position, extending the hips over approximately 2 seconds. Inhale during descent, expel during ascent. Commence with 1 set of 5 to 8 repetitions and advance to 2 to 3 sets of 15 to 20 repetitions using meticulous technique. Advancements: reduce seat height to enhance range of motion. Eliminate the chair while preserving the same depth-free squat. Incorporate external load handheld weights, vest to augment resistance and power requirements. Employ tempo variations, explosive concentric, followed by sluggish eccentric to enhance power and rate of force development. Alterations and security individuals experiencing knee pain or those who have undergone recent joint replacement should adhere to surgical precautions and restrict movement to a comfortable range. Observe trunk flexion and knee valgus as markers of technique deterioration. Commence with isometric wall sits or half squats if dynamic movement is intolerable. Primary exercise bird dog with systematic progression, exposition, and substantiation. The bird dog, including contralateral arm and leg extension from a quadruped position, is the primary exercise in the Copenhagen protocol. Gerontology and physical therapy researchers recognize this contralateral stability movement as highly effective for enhancing core stability, postural control, spinal health, and neural integration, with emerging evidence indicating potential advantages for bone remodeling when executed with adequate intensity and progressive overload. A 2024 article in the Journal of Gerontology described the bird dog as the most effective exercise for healthy aging, corroborated by a 2-year observational study at the Mayo Clinic involving 500 individuals over 60. In that study, participants who engaged in bird dog progressions exhibited significant enhancements in clinically evaluated core strength, decreases in lower back discomfort, and considerable reductions in fall risk. The Mayo Clinic cohort demonstrated a mean increase in bone mineral density in the lumbar spine and proximal femur, a finding of substantial importance considering the usual age-related bone loss. This indicates that properly administered axial loading stability exercises can at least halt and in certain cases partially reverse age-related bone loss. Mechanisms. The bird dog exercise exerts concurrent mechanical and neurological requirements. Maintaining contralateral limb extension mechanically necessitates the coordinated activation of deep intrinsic stabilizers, transverse abdominis, multifidus, and pelvic floor muscles that serve as an internal corset supporting the spine and offering a firm foundation for limb movement. The integration of axial loading limb tension and repetitive isometric holds imparts strain to bone and connective tissue, stimulating osteocyte mechanotransduction pathways that promote osteoblastic activity in alignment with current theories of strain sensitivity. The cross pattern necessitates bilateral interhemispheric coordination and contralateral firing, enhancing callosal connection and subcortical stabilizing networks. Clinical and imaging research associates patterned bilateral training with enhancements in specific cognitive areas, such as working memory and visuomotor integration, as well as minor structural alterations in gray and white matter metrics. Guidance and advancement. Commence in a quadrupedal position on a stable surface with hands positioned beneath the shoulders and knees, aligned under the hips, ensuring a neutral spine and a slight engagement of the abdominal muscles. Gradually extend the right arm anteriorly and the left leg posteriorly, creating a linear vector from fingertip to heel while maintaining a level pelvis and shoulders and preventing rotation. Maintain the position, then return and replicate on the opposite side. Exhale during extension. Maintain regular respiration while holding and inhale at return. A systematic progressive framework. Weeks 1 to 2 emphasize form 5 to second holds 5 repetitions per side, 3 sessions weekly. Weeks 3 to 4 extend holds to 10 seconds, 5 to 8 repeats each side. Weeks 5 to 6 include minor pulses at the end, range 1 to 3 pulses of approximately 1 inch while sustaining a 10-second hold. From week 7 onwards include proprioceptive challenges, intermittent eye closure. During holds extend, hold durations, 15-20 seconds, increase repetition volume, and incorporate advanced variations, unstable surfaces beneath hands or knees, resistance bands for limb extension, irradiation, and sophisticated signals. An advanced cue intentional opposite force creation or irradiation can improve recruitment. By actively extending the hand and pressing with the foot without altering position, longitudinal tension enhances overall muscular activation and perceived stability. Electromyographic investigations in relevant situations demonstrate heightened activation of trunk and limb musculature, in response to such signals, potentially enhancing the stimulus for neuronal and musculoskeletal adaptation, alterations, and security. For wrist or knee discomfort, execute the exercise using fists on forearms or on cushioned support. A prone limb extension progression laying supine and elevating alternating limb pairs can function as an initial regression. For individuals unable to attain complete limb extension due to shoulder or hip disease, reduce lever arms, flex the knee or elbow, and gradually extend lever length as tolerance permits. Observe for compensatory lumbar extension or pelvic rotation. Reduce load or time if form deteriorates. Program formulation, execution, and evaluation. Temporal efficiency and compliance data from the Copenhagen trial suggest that compliance with a meticulously structured targeted routine necessitates significantly less time than traditional aerobic guidelines while yielding superior and clinically significant results. Participants in the focused group received enhanced strength mobility, pain alleviation, and fall prevention results in approximately 75 minutes per week, in contrast to about 180 minutes per week in the walking group. This discovery underscores the importance of exercise quality and specificity movements that impose stress on pertinent tissues and test neuromuscular control rather than merely the aggregation of low-intensity activity. Time-efficient programs are especially important for older persons who encounter obstacles including restricted discretionary time, chronic pain, and mobility limitations. Concise, focused sessions that exhibit immediate functional advantages may enhance motivation and promote long-term adherence. Framework of the session. A suggested weekly framework for clinically stable older persons may consist of 3 non-consecutive sessions, e.g., Monday, Wednesday, Friday, each lasting roughly 20 to 30 minutes and including concise warm-up, 5 minutes mild marching in situ, ankle and hip mobility exercises, and light shoulder rotations. Objective is to elevate core temperature and prepare proprioceptive systems. Primary targeted exercises 15-20 minutes, alternate concentration among the 5 movements to mitigate fatigue and uphold training quality, e.g. bird dog and seated leg lifts on day 1, wall push-ups and chair squats on day 2, heel raises and variations of bird dog on day 3. Cool down and balancing exercises 3 to 5 minutes, regulated respiration, calf stretching and single leg stance practice with assistance as required. Principles of progression. Progression must be personalized and directed by technique, symptomatology, and objective metrics. Repetition, maximum hold duration, timed sit-to-stand gait velocity. Employ the 2x2 rule, increase load or volume when an exercise can be executed for 2 successive sessions, with 2 or more additional repetitions beyond the designated target, without sacrificing form or experiencing significant discomfort. Highlight periodization cycles of heightened intensity, succeeded by deload weeks to prevent overuse and enhance adaptation. Evaluation, contraindications, and safety considerations. The initial screening must encompass a review of medical history for unstable cardiovascular disease, uncontrolled hypertension, recent myocardial infarction, uncontrolled arrhythmia, severe pulmonary disease, or recent orthopedic surgery. Evaluate baseline mobility balance timed up and go single-leg stance, cognitive function, and pain levels. Contraindications to particular progressions, e.g., advanced spinal instability for substantial axial loads must be recognized and addressed. Initiate supervised training for those at elevated risk of falls, those with cognitive deficits or numerous comorbid conditions. Community programs must guarantee that instructors are proficient in safely modifying and advancing activities. Integration of nutritional and medical management exercise is most efficacious when integrated with a focus on nutritional status and pertinent medical treatments. Sufficient protein consumption in relation to body mass and meal distribution facilitates muscle protein synthesis and remodeling. Vitamin D adequacy promotes skeletal health and muscular performance. Evaluate and supplement according to regional protocols. For persons with osteoporosis, collaborate with treating clinicians while advancing loading techniques. Pharmacologic therapies for osteoporosis should be maintained as recommended and included within a holistic strategy. Address polypharmacy that could compromise balance, sedatives, antihypertensives with orthostatic effects in conjunction with primary care. Assessing outcomes and clinically significant change. Trackable objective measures encompass sit to stand, 5 or 30-second test, and timed up-and-go assessments for functional mobility. Gait velocity over 4 meters serves as a reliable indicator of health outcomes. An enhancement of 0.1 to 0.2 ms is often regarded as clinically significant. Hand grip or pushing dynamometry as indicators of upper body strength. Calf raise endurance counts and the maximum number of single-leg heel raises. Incidence of falls prospectively documented and measures measuring fear of falling. Assess bone mineral density with DXA when possible, acknowledging that observable changes may necessitate 6 to 12 months, along with sufficient loading and systemic support. Anticipated schedule for modifications. Neuromuscular enhancements balance motor control. Initial strength increases are typically evident within 4-8 weeks as a result of brain adaptation. Hypertrophic alterations and osseous remodeling necessitate prolonged exposure, generally spanning several months to a year, alongside growing overload and sufficient nourishment. Pain alleviation and enhancements in gait velocity and stair performance are frequently observed within 6 to 12 weeks in interventional investigations. Execution in clinical and community environments. These 5 exercises are appropriate for personalized prescriptions, small group sessions, and home-based programs with initial supervised guidance. It is crucial to train community-based instructors to implement standardized progressions, oversee technique, and identify warning signs to ensure the safe scaling of interventions. Telehealth delivery with video education and remote monitoring has opportunities for broader implementation contingent upon the incorporation of early assessments and regular in-person evaluations. Strategies for equity, accessibility, and adherence. Programs must account for socioeconomic and physical accessibility obstacles. Basic apparatus chairs. Resistance bands, ankle weights is cost-effective and readily accessible. Instructional materials must be translated and modified for cultural appropriateness. Strategies to enhance adherence encompass goal planning, delivering fast feedback, facilitating group sessions that encourage social interaction, and use concise objective assessments to illustrate early progress and essential motivation for older persons. Constraints and research deficiencies. Although randomized trials and extensive cohort studies endorse the effectiveness of targeted resistance and balancing workouts, variability in protocols, outcome measures, and participant characteristics hinders direct extrapolation. The Copenhagen study provides persuasive population-level evidence. Nonetheless, additional randomized pragmatic trials in varied healthcare environments would enhance external validity. The mechanistic connections between particular exercise routines and cellular indicators of lifespan are a continuing focus of research. Existing evidence is indicative but not conclusive. Integration and summary. Consolidated evidence suggests that although walking remains beneficial for older adults' health, especially for cardiovascular fitness and social interaction, it may not be adequate as a standalone approach to effectively address the complex physiological challenges of aging. A focused program that combines wall push-ups with hold-sitting leg lifts with incremental resistance, standing heel raises with balancing challenges, modified chair squats, and systematic bird-dog progressions offers a comprehensive and precise stimulus profile. These movements collectively target key areas of age-related decline, sarcopenia, and reduced rapid force production. Bone demineralization and deficits in mechanosensitivity, impairments in balance, proprioception, and vestibular integration, as well as specific cognitive and neural integration reductions. They produce a synergistic effect by augmenting functional strength across various planes of motion, improving the mind-body connection through proprioceptive and vestibular challenges, stimulating bone and neural tissues at a cellular level through mechanotransduction and cross-lateral neural activation, and maintaining or restoring the abilities necessary for independent activities of daily living. From a public health standpoint, interventions that are time-efficient, easily instructable, and yield substantial clinically significant advantages are appealing for expansion. The Copenhagen findings indicate that focused, specific exercises with modest weekly time commitments result in more significant reductions in falls and enhancements in strength, pain, and mobility compared to prolonged walking durations. This emphasizes the necessity of prioritizing exercise quality and specificity over the mere duration of low-intensity activities. Implementation must be followed by suitable screening, personalized advancement, and interaction with nutritional and medical management. The elderly individual possesses significant potential for adaptation, restoration, and fortification. Studies involving participants in their 80s and 90s confirm that starting a program consisting of the previously mentioned exercises, even when initiated anew at advanced ages, can result in significant enhancements in measurable strength, mobility, balance, bone health indicators, and certain cognitive functions. When implemented with suitable teaching oversight and advancement, these 5 specific exercises represent an evidence-based, time-efficient approach to significantly diminish fall risk, boost functionality, and improve quality of life in older persons. Subsequent extensive implementation studies and mechanistic analyses will enhance appropriate dose progression and integration with comprehensive geriatric care models. However, existing data endorses the widespread use of targeted multimodal movement prescriptions as fundamental to healthy aging. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement.